All right, so we'll start with antibiotics. There's going to be two parts to this. There's a lot of antibiotics that will cover a lot of different classes. So we broke it up in two parts. It's a lot easier to kind of discuss it that way. So when we're talking about antibiotics, we're going to start talking about microbial infections. So we're talking about something of bacteria that attacks the body's defense systems and defense mechanisms that the body normally has. We do have actual defense systems in our body. We have physical barriers, which are going to be, of course, your skin, ciliated respiratory mucosa. That's another actual physical barrier that the body uses to be able to protect itself. We have physiologic defenses, like our gastric system is the acid in our gastric system is a defense system for preventing infections because of the acidity in it. So that's another defense system that we have. And we have our immune system, right? And we have, those are what we use to produce antibodies against what we are exposed to. So those are going to be your defense systems. So part of your immune systems are your cells that are involved in the immunity, like your macrophages. Remember the very beginning of the semester when we talked about the macrophages, your neutrophils. Those are all part of that immune system that helps us to be able to protect ourselves from invading bacteria. Bacteria are going to be categorized by basically about how they look. So we have bacteria that come in different shapes or different morphoric entities. So they look like coccyx or bacillus, and those are different types. That's how we categorize them. And when we talk about the different antibiotics, we're going to talk about the antibiotics that affect the specific the type of bacteria. We also categorize them by how they respond to a gram stain procedure. So when they put a gram stain, it's like actually adding a chemical stain to the bacteria. And if it stains purple, that's basically a gram-positive bacteria. If it stains red, it's a gram-negative bacteria. And the difference basically is that your gram-positives have a much thicker cell wall, and your gram-negatives, the cell wall is thinner, but it's a much more complex type of bacteria, which makes the gram-negative bacteria much harder to treat. Because what happens is that now the drugs have a harder time penetrating through the cell wall because it's a much more complex bacteria. So if what happens is that if basically the bacteria attacks the system and the system has an ineffective process that occurs, and so it tends to overwhelm the body's defense system, then that's when the patient is going to start to show clinical signs of the infection. So most of the time, some patients don't even show signs of infection because their bodies are able to tolerate the attack, and their immune systems are strong enough that they're never going to show a clinical sign. But your older clientele, your elderly patients, your immunocompromised patients, those are the ones that are going to probably show much more earlier signs of infection because they have a weaker immune system. Their barriers against bacteria is going to be weakened. So your healthcare associated infections, those are going to be your community associated infections. These are infections that are acquired by a person that has not been hospitalized or had a medical procedure recently. So these are community associated. So they haven't been in the hospital, okay? Your nosocomial infections, those are the ones that everyone knows about. Those are the ones you get from being in the hospital. They're acquired during the course of receiving some type of treatment for another condition, okay, in the healthcare setting. So they went in for, let's say, heart issues or a cardiac dysrhythmia, and while they were there, they got a UTI from the Foley. Okay, that's your typical nosocomial infection. Nosocomials will usually occur they start to occur after 48 hours of admission. They are on one of the top 10 leading causes of death in the U.S. It's from a nosocomial infection from a patient being in the hospital. They're the most difficult to treat because the causative agents have been exposed to very strong antibiotics in the past and are now they're most drug resistant. And that's what makes them the most virulent. So nosocomial infections are usually the most hardest to treat, and that's why patients usually can get septic and ultimately die from these types of infections because they're the ones that are exposed to all the different types of antibiotics. So they've been able to mutate to the point where now they're very difficult to treat. MRSA is going to be one of your most common examples of a nosocomial infection in that way. Most common health-associated infections are going to be your UTI, your surgical site infections, bloodstream infections, so anything like makes it infection of the blood, makes the patient septic, or pneumonia. Those are your most common. The most health-associated infections, the units in the hospital that have the most health-associated infections are going to be your critical care units, because of course that's where you have your most immunocompromised patients. Your dialysis unit is going to be another one. Oncology units, transplant and burn units. And if you see the trend with all the units, they're all the units where your patients that are immunocompromised or have an alteration in their defense system is more prevalent. So these are the units where those types of patients kind of are more prevalent to be in. And that's why those are the ones that are higher in nosocomial infections. The host defenses are then compromised. Most common mode of transmission is going to be your direct contact. So that makes that hand washing is your most single most important way of preventing nosocomial infections is hand washing. That's why we stress it so much. That's why Joint Commission stresses it so much. And all the hospital policies and all the hospital, when their rates are really high for nosocomial infections, the most thing they do is they start to do a whole campaign on hand washing and making sure that the nurses and the staff and everyone's washing their hands, because it is the one way of being the most important way of preventing these types of infections. When we talk about disinfectants are sort of like they protect you from, they kill the microorganisms, but they kill them on non-living things. So you want to make sure that disinfectants are not used on living tissue because it will cause chemical burns or it will cause damage to the living tissue. So antiseptics are the ones that you use on living tissue and living things. And that's going to inhibit the growth of the organism, of the bacteria. So your antiseptics will inhibit the growth. Your disinfectants actually kill the organism that's on the non-living thing that's kind of sitting there on that surface. Kind of like a review of your pharmacology, the uses of antibiotics, the reasons why we use it. There's three main reasons. We do empiric therapy, and that is using antibiotics that can best kill the organism, known to be the most common cause of the infection. So that's an empirical way of treating it. We have an educated guess of what the organism is, and we treat it with that antibiotic. It's usually done because you've done so many of these types of infections, we know that this bacteria works. I mean, this antibiotic works for this bacteria. And that's usually how we use empiric. Definitive, with empiric also, just an aside, cultures should be obtained before we do the drug therapy is initiated, whenever it's possible. And that's because we want to be able to make sure that even though we're treating empirically, we want to make sure that if we continue treatment, that we are treating the bacteria with the right antibiotic. So we want to obtain the culture before we actually give the antibiotic, so that way if we're not giving the right antibiotic, we can change it once we get the cultures back. They're going to test the susceptibility of various antibiotics when they do the cultures. And usually the culture and sensitivities are available 48 to 72 hours after we've done them. They could be done from the blood, depending where the infection is. So if it's a blood culture or a sputum culture or an actual wound culture, all of those could be done, and they're done prior to starting that antibiotic. So with definitive therapy, we use the most narrow spectrum and least toxic drug based on the culture and sensitivity results. So remember that with definitive therapy, when we're doing like empirical, we're going to probably use what we call a broad spectrum antibiotic, which means that it usually covers most bacteria and it's able to penetrate most bacterial cell walls, where with narrow spectrum, it's much more selective. So these antibiotics usually only treat much more selective bacteria. But because we're doing definitive therapy, we know that this antibiotic is going to cure or affect this bacteria. So we've done the culture and sensitivity. It's come back with what antibiotic is going to be able to eradicate it. So we're not guessing in this point. So that's why we use the most narrow spectrum. Narrow spectrum antibiotics, again, will only affect a few of the bacterial organisms. And then the other reason why we would give antibiotics is prophylactic or preventative therapy. And this is when the patients are going to be at risk for getting an infection or a contaminant, and we want to prevent them from getting an infection. So usually we give it before a procedure or before a surgery. We use to prevent any types of infection if we know they're most likely to be exposed. They do need to be given 30 minutes prior to a procedure in order to ensure that adequate tissue penetration has occurred. So now that you guys are mostly doing OB, you'll see that we give everyone who's getting a C-section antibiotics, right, prior to their C-section, usually an hour before the cord is cut. We do it also for the baby and as well for the mom, so that we can help prevent her from getting an infection. And then broad spectrum antibiotics, like I stated before, are going to affect mostly your more common bacteria and a greater number of different bacteria and organisms. So that's why they use broad spectrum antibiotics, because we could use them for various different types of organisms. When we are talking about therapeutic response, again, we're looking for the signs and symptoms that are going to show that the infection is decreasing. That's how we know that we're getting the effect of the antibiotic that we want. Okay, a subtherapeutic response is going to be the exact opposite, right? So your antibiotic isn't working; it doesn't improve the signs and symptoms of infection. So because it's not improving the signs and symptoms, then we know that possibly maybe that antibiotic isn't covering that bacteria or that organism. We have super or supra infections and opportunistic infections, And those are your super drugs. We talked about those a little bit. Those, like your nosocomial infections, they're going to be the ones that have been exposed to so many different types of antibiotics that now the body's own mechanisms can't affect them. And now the organisms are able to take havoc and wreak havoc in the system. So examples of your super infections or your nosocomial and other nosocomial infections that are hard to treat, like your yeast infections or your C. diff. So C. diff is like a supra, meaning that patients are on antibiotics and they get C. diff from being on antibiotics. Same thing with yeast infections. Patients take antibiotics, they can get yeast infections from being on antibiotics. So how do we test the efficacy of the antibiotics? Again, the host-specific factors. We are going to make sure that we're giving patients so we don't want to overprescribe them, so we want to make sure that we're giving the right types of antibiotics for the right types of organisms. You don't want to you don't want to try to initiate antibiotic resistance. So you're trying to narrow down. So that's why sometimes now, even in the last few years, when you go to the pediatrician's office, they stopped giving antibiotics for every little infection. And that's because we were creating all of these types of superbugs. So we want to make sure that we're only giving antibiotics for infections or bacteria that we know are going to cause a detriment. If we know the body's strong enough to withstand it and fight it off, we let it ride its course, okay, for the most part. So food and drug or drug and drug interactions can affect the efficacy of the antibiotic therapy. The other thing that can affect the efficacy is, again, patients tend to not complete their antibiotics. So the first sign of the patient's feeling better, they're like, oh, I feel better, and they stop their antibiotic. When they're supposed to take it for a full 10 days, they take it for 4, okay, or for 5. That's what causes a lot of these resistant drugs, because the bacteria was already exposed to that antibiotic, didn't completely eradicate it, didn't completely get rid of it, and now the bacteria and that organism is like, whoo, wait a minute, I know now they tried to get me with this, I'm going to fight it off, and it creates a resistance to that specific antibiotic. And we're kind of running out of antibiotics. You know what I mean? Like we've got so many, and now we've created so many different types of antibiotic resistant bacteria and organisms that now we're kind of running out of them. And so it's getting really hard to kind of treat these really bad organisms that aren't reacting to any types of antibiotics that we have. Many people do have allergies to medications and allergies to the antibiotics. So one of the common anaphylactic reactions that you might see is going to be to penicillins or to sulfur drugs. Your signs and symptoms of your anaphylactic reactions are going to be your flushing, itching, your hives. Patient might start to feel anxiety. Their pulse might get fast and irregular. Throat and tongue is going to start to swell. You do really want to assess the allergy. Nausea and vomiting is not an allergy, okay? Sometimes even a rash may not be an allergy itself. It might be a reaction, but it may not be an allergic reaction or an allergy to that medication. So we need to be kind of really asking questions when the patient says they're allergic to certain things. What kind of reaction was it? You need to really kind of ask those. Patients with genetic abnormalities like your G6 or PD deficiencies, they're going to have trouble tolerating certain antibiotics. And then there's some antibiotics that do not penetrate the lungs and the bones. There's certain abscesses. So those are also going to be much more difficult conditions to treat as well. So those are things that we want to make sure we look at. I know that sometimes patients can actually be allergic to things that are really benign, not just even allergies, but even different types of antibiotics. I have an anaphylactic reaction to Zantac, which now is over the counter, but when I first took it, it was a new drug that they had just come out for an antacid, and I have GERD. And so when the doctor gave it to me, luckily he gave it to me at the hospital where I was working. He gave it to me in the morning when I saw him, and then I went to work. And I took it while I was at work, and I was like, okay, fine, because my gastritis was really bad and my GERD was really bad. And about 25 minutes later, I felt really bad. Like, I was like itchy, and I was like kind of like flushed, and I went to the bathroom, and I started getting really nauseous, and I had diarrhea, and I was nauseous and throwing up and diarrhea, and I was like almost like to the point where I was kind of hyperventilating, and I was in the bathroom for I didn't really realize how long it was, but it must have been like 25 minutes in there, where one of the other nurses came and knocked on the bathroom door and was like, "Are you okay?" And I was like, I don't know. I just feel really bad. And by the time I opened the door, literally my whole face was because I hadn't looked at myself, I had blotches everywhere. And I couldn't breathe. And I was just like, and she's like, what did you take? That was the first thing she told me. I was like, I just took Zantac. What are you talking about? She's like, you're allergic to it. I would have never thought I was allergic to such a benign medication. But ended up in the ER with salumedrol, epinephrine, all the works, with a complete anaphylactic reaction. So if I was home taking Zantac, I probably would have never made it, because I would have never gone to the hospital or never really realized that I needed to go. I just thought it was part of my illness, because it was all GI stuff that I was having, and all the symptoms were GI. Until they looked at the roof of my tongue and the back of my hair. I had huge welts on my back, the top of my tongue. My throat was starting to close off already. So they literally loaded me up with Benadryl and salumedrol, epinephrine, the whole works. So it can be even benign kind of stuff like that. So anaphylaxis is really no joke. Other things too with anaphylaxis is that it doesn't usually happen in one shot. So sometimes it could be just an accumulation of that antibiotic. So a lot of times with penicillins, the patient's been getting penicillin all her life. When she was little, she got it, and then, maybe she got it again when they were in middle school, and then again, maybe in high school. And now she's in her 20s or 30s, and she gets another dose, and she gets penicillin again, and boom, she has a reaction. It's because she reached her threshold. Some patients have a specific threshold of resistance that they can tolerate, and then once they reach that threshold, that's when they start to have that anaphylactic reaction. So it doesn't necessarily happen all at once when they first take the medication, but they do. They can get it accumulation through time. And usually it will take about anywhere between 30 minutes or so before you start to notice a reaction. If they're having one, it's going to happen within the 30 minutes or so. Key points to remember with antibiotics. Your most common adverse effects of antibiotics, again, are going to be your nausea, vomiting, and diarrhea. Now, these are adverse effects. These are effects that we would expect, right? They not necessarily mean that they're allergies. They're just adverse effects. The antibiotics will cause these to happen. Antibiotics should be taken for the entire prescribed length of time. Remember that many people like to stop taking them once they start to feel better. Super infections may arise during treatments because they've killed off all the normal flora. So your super infections, like a yeast infection for women, is because we're getting antibiotics. Antibiotics, especially if they're broad spectrum, they're not specific. They don't kill just bad bacteria. They also kill good bacteria. And in doing that, it breaks the balance of the normal flora, and then we leave ourselves susceptible to growth of other things, especially yeast. So again, signs and symptoms that you might see for the super infections are going to be your fever, perineal itching or oral lesions, vaginal irritation for women, discharge. They might start to see a cough or lethargy. All part of those super infections that start to come up from taking antibiotics. All antibiotics will reduce the efficacy of contraception. And we learned about contraceptions in OB when we did theory, but remember that you need to use a alternate or a barrier method while you're on your antibiotic, during the time that you're on antibiotics, while you're using your birth control. So you don't stop your birth control, you continue taking it, but you have to use a second method because it will reduce the efficacy. And that's one of the biggest things. You'll talk to anybody who's been on birth control and got pregnant while they're on birth control. They'll tell you, oh yeah, I was on antibiotics and I didn't use the second method, and that's how I had baby Jane. Okay? And so that is one thing important to be teaching, especially to our reproductive age patients. General mechanism of action for antibiotics. You have your bacteriostatic, which help to slow the growth of the organism so that the immune system can then destroy the organism itself. So your bacteriostatic doesn't eradicate it, it just slows its growth. It allows the immune system to do its job without the bacteria growing in too much of an excess that will overwhelm the immune system. And then you have your bactericidal, and that one will kill the organism completely. All right, so we start with sulfonylureas, or your sulfonamides, your sulfa drugs. These drugs will all start with sulfa. So you have your sulfamethoxazone plus your trimethoprim and co-trimethylazone, which is your Bactrim. All together, it's 3 different types of sulfa drugs, or combination of sulfa with other classes, and that's your Bactrim. It's your most common. Then your sulfadiazine and your trimethoprim. This specific mechanism of action is bacteriostatic. So remember what bacteriostatic is. It slows the production of the organism. So it inhibits its growth. This is going to inhibit the production of folic acid, which is needed for the DNA and RNA production. So it's and that's how it affects the organism, because the organism is a bacterial, uses the folic acid of the body in order to be able to continue to grow and replicate DNA, and then this will inhibit that production. Sulfa drugs, adverse effects that you're going to see: hypersensitivity. It does cause a fever, followed by a delayed rash. One of the biggest things with sulfa drugs is that it can lead to Stevens-Johnson syndrome. So if you start to see a rash, that's kind of general rash with the sulfa drugs, you should stop it immediately, let your prescriber know, so that way it can be tested to make sure that it's not leading to Stevens-Johnson syndrome. Blood dyscrasias are another adverse effect. So any type of blood disorders, so like anemias or leukopenia. Kernicterus in newborns, that's when babies are born with elevated bilirubin levels, and it starts to deposit under the skin and in the brain. And your crystalluria, which means that you have crystals that form in the kidneys and in the bladder, the uterus, and this can cause irritation and an obstruction. So these crystals can lead to ultimately kidney stones if it's not observed. So you need to watch these patients for their urine output, making sure that they're drinking plenty of water to avoid the accumulation of the crystals, and make sure that they're going to be flushing them out. Okay, so that there's more dilution in the bladder, so that the crystals don't end up forming bigger clumps and then cause obstructions. Agranulosis or agranulocytosis. It's also known as agranulosis or granulopenia. This is a specific acute condition which involves severe and dangerous leukopenia. So it's a very low white blood cell count. Most commonly, the neutrophils are the ones that are affected. And this is part of your blood dyscrasias for your adverse effects. And we talked about your kernicterus, which is also very severe for newborns as well. Contraindications for sulfa drugs. Again, so any patients that have folate deficiencies, which are gonna make them a higher risk for getting anemias. Patients that are pregnant or infants that are younger than 2 months of age. You do not want to give them this any type of sulfur drug because of the potential for kernicterus. Remember, kernicterus can also happen in utero. So if the pregnant woman is taking Bactrim for an infection while she's pregnant, it can cause the collection of bilirubin under the skin. So when that newborn is born, it'll be born canary yellow or with a high level of bilirubin. And then we have to treat. Depending on how long the baby was exposed or how long it's had it, it can actually lead to being collected in the brain. And the babies can actually die. So it's one of those category C to D drugs for pregnancy that we do not give. You want to watch giving these types of drugs. So it's a caution. It's not a complete contraindication, but it is a caution for patients that have impaired renal function because of the crystallizations that can occur. And those patients that are 65 and older, and those that are on ACE inhibitors or any ARBs, and that's going to be because of their risk for hyperkalemia. So these are cautions. So maybe if the sulfa drug is the best drug for whatever infection they may have, then these are monitoring that you have to do. These patients are going to be assessed for these types of risk factors that they have. Sulfa drugs will interact, meaning that they will increase the effects of specific other medications, warfarin being one of them. It's going to cause, it can cause hemorrhage when they're on warfarin and taking a sulfa drug. So these patients need to be monitored for their PT and INR levels. Patients on phenytoin and oral hypoglycemics, sulfonylureas, all of them can kind of potentiate and cause hypoglycemia. So you need to monitor the glucose levels. As a nurse, nursing considerations, what are you going to be looking for? Again, you want to assess the skin because remember the potential for Stevens-Johnson syndrome. So you're looking for a rash or a specific type of area that has a rash, especially around the dermatomes. You're going to monitor their CBC, monitor their renal function, especially if they're on long-term therapy of this sulfa drug. They have a higher potential for the crystalluria, and you want to encourage fluids. These patients should be taking anywhere between 2 and 3 liters of fluid in 24 hours. You want to be able to prevent those crystallizations. Important patient teaching aspects that we do with sulfa drugs. Remember, if they start to produce a rash, you want to stop the medication. Like all antibiotics, you want to make sure that they take all of the medication. So just because they start to feel better doesn't mean they stop. So you want to make sure they're taking all of their meds. And again, like we said before, if they're on any contraceptive, especially hormonal, They need to make sure they're using a barrier method because it will reduce the efficacy. Phenytoin, for those who don't know, it is an anti-seizure drug. And the sulfonylureas are your oral anti-diabetic drugs. So those names should be familiar to you guys. So for beta-lactam antibiotics, they have a chemical structure specific. These antibiotics have a specific beta chemical structure that has a certain ring around them. There are 4 specific subclasses of your beta-lactams, and those are going to be your penicillins, your cephalosporins, your carbamazepines, and your manobactams. These are your 4 main classes of your beta-lactam antibiotics. Your penicillinase, your organisms that produce beta-lactamase do bring the ring rendering antibiotic useless. So basically, your penicillinase is a specific enzyme, and they're going to make these this ring around the antibiotics, which this is how the antibiotic works. It kind of helps to create this ring around the organism, and it'll render it useless. So we need to watch out for those penicillinase. And then you have your beta-lactamase inhibitors. Those are actually going to protect the ring and keep it intact. Thing is that they're not always effective. And examples are your clavulanates, your tazobactam, and your sulbactam. Those are all specific beta-lactamase inhibitors. Basically, with beta-lactamase, they are time-dependent antibiotics. So the amount of time that the drug is above the therapeutic level is going to be crucial for the maximum amount of bacteria that's killed. So most of these beta-lactam antibiotics need to be in the system for a specific period of time in order for them to be as effective as we would want them to be. Your MIC is going to stand for a minimal inhibitory concentration, your MIC. And that's going to be the lowest concentration of the drug needed to kill the certain amount of bacteria. So that's why they're time dependent. So it really depends on their MIC in order to make sure that they're going to be the most effective. So we start with your beta-lactam antibiotics. Penicillins is going to be, again, your first class. Meds are usually used for prevention of bacterial endocarditis prior to dental or any other different types of procedures. Penicillin was derived from fungus. They have narrowed them down to 4 groups: your narrow spectrum, your broad spectrum, your anti-staphylococcal, and your anti-pseudomonal, which becomes more of an extended spectrum. Those are your 4 groups of penicillin. The uses for penicillins: your gram-positive cocci, they're going to help to kill strep pneumonia, like regular pneumonia, meningitis. Your viridans, they're gonna help to treat the endocarditis and things like strep throat. So the bacteria that cause strep throat, these are meds that we would use for that. The way they work, these are bactericidal. So unlike the other one, which just slowed the growth, your bactericidal actually kill the organism. And because the way they work is they weaken that cell wall. Penicillins plus your beta-lactamase inhibitors are going to be combination antibiotics. And the 4 that are there are your most common combination ones. So your ampicillin and sulbactam, which is your unicin, amoxicillin and your clavulac acid, which is your augmentum, your ticarcinin plus your clavulactin acid is your timentin. And the ones that you will see a lot in the med-surg floors, your piperacillin and your tazobactam, which is your zosyn. So these are your 4 main combination of penicillin and your beta-lactamase inhibitors. These are the ones that are the most common. These are the ones that you're going to see in most of the time when you're in the hospital setting. So your narrow spectrum, Pen-G, benzathine. Pen-G benzathine is a very specific narrow spectrum drug. It's given IM. What do we treat Pen-G with? What do we treat Pen-G with? Syphilis, yes. Very good. It's thick, white. We have to use a 21 gauge needle, and we have to give it in a large muscle. Pen-V, penicillin V, is one that we can give PO. Those 2 are going to be your most common narrow spectrum drugs. Now your broad spectrum antibiotics or your broad spectrum penicillins that we are used to, your amoxicillin is one of them, and that's given PO. Your amoxicillin and clavulanates, which is your augmentum, also given PO. And then ampicillin, which can be given both PO and IV. Those are your more common. There's a lot of other ones, but your more commons that we see, broad spectrum-wise, are going to be those. Your anti-staphylococcal, Nacillin is your most common. That's going to be given IM and IV. And then your anti-pseudomonal, which is part of your extended spectrum. These are going to be often used for those hospital-associated infections. And these are your Timentin and your Zosyn. And both of those are usually given IV. Zosyn is one of the ones that are used for empiric therapy until we know exactly what it is. So Zosyn is one of those drugs that we like to use when we're treating something empirically because it has a really good coverage. And then until we get the CNS back, that we know specifically if we need to change it, but we can start them on Zosyn in order to be able to get them treated, or at least get the process going. Adverse effects that we're going to see with these, again, allergies. You can see anything from like urticaria, bursitis, dyspnea. Things with allergies for penicillin is that you do want to report it as soon as you start to see some type of allergic response. That way we know about it. Just like I said with anaphylaxis, you want to be able to observe them for at least 30 minutes after you administer the drug. Anaphylaxis is usually more common with the drugs that we inject, like IMs or IV, because it occurs much quicker. But It can be also with a PO as well. It's just not as seen as often. IV forms do have a large amount of sodium or potassium. They can cause hyperkalemia, hypernatremia. So when you're giving these antibiotics, you want to be able to monitor those lab works. You want to monitor their cardiac status, okay, because of the effects of potassium. What are we looking for cardiac status? What can happen if their potassium is off? They could get dysrhythmias, right? Interactions that we see, aminoglycosides. Aminoglycosides are another group of antibiotics. And when we are seeing, we can have an interaction when penicillins and aminoglycosides are given together. It usually happens where it does inactivate the aminoglycoside if it's in the same IV. So if we know we have to give both of these different types of classes, we need to know that we need to give them 2 IV sites. We can't give it in the same site because it will inactivate the other one. Okay, so it does inactivate, penicillin will inactivate the aminoglycoside. Probenecide, which is a uric acid reducer. It will delay the excretion of the penicillin, so it's going to stay in the system longer. So there's more chances of having a reaction to it. And then warfarin, penicillin will decrease the vitamin K that is produced in the gut. So it can increase the anticoagulation of warfarin. So warfarin is a med that we have to watch out for if they're taking penicillin as an antibiotic. Contraindications that you do not want to give penicillins for, again, if they've had any type of past allergy to penicillin, even cephalosporins or imipafim, those are kind of like, can have cross sensitivity to penicillin. So you don't want to give it to them also if they've had a cross sensitivity, if they've had an allergic reaction to those other drugs, because they are very close in family and in structure, and they could cause a reaction. So contraindications to penicillin are going to be allergies in the past, cephalosporins, and imipafins. Also, patients that are have renal dysfunction, you don't want to give it to them because they're going to have much more issues with excreting the drug. The longer they stay in their system, the longer they could have reaction, or the more risk for reactions that they have. And then beta-lactam antibiotics, again, the last ones with penicillin, your nursing considerations. Make sure that you're assessing for past allergies, even those that are potential for cross-sensitivities. Monitor the allergy. So if it's an immediate or a delayed response, you want to make sure that you're looking at what type of response they're having. You're looking for labs, so you're looking at their potassium levels, you're looking at their sodium levels, okay? Especially high concentrations in the IV. You might see these because if they're given IV these meds are kind of go right into the system, so they're going to affect those labs. So you're going to monitor those labs on those patients as well. Knowledge-wise, remember, 30 minutes after administration is where they're at the most highest risk for an allergic reaction, so that's what you're going to be looking for. If they're given IM, these are thick drugs, so you want to use a 21 gauge needle. You want to use a larger muscle. You don't want to give it in a small muscle with a small needle. It's going to be really hard to kind of give it through there, and it's going to burn a lot more. If it's given IV, you want to make sure you have the enough dilution and enough time. Penicillins do burn going in IV-wise. They do sting. So lots of times we end up piggybacking them with like another carrier fluid or a fluid that we could dilute it with. or we run it in a longer amount of time. So like if it says to run in 30 minutes, because it's only 50 mLs, we run it in an hour so that it burns less, okay? Because we dilute it a little more, or we dilute it with more fluid. We give it at the same time as the fluid, so that instead of putting your antibiotic higher and your fluid and your primary lower, you kind of keep them steady at the same height, and then that way they'll both run at the same time, so it helps to dilute it better, okay? That's just because it's going to burn so much going in. Also, you want to make sure if they're taking a PO to give with water. Anaphylactic, you want to be able to give them epinephrine, have O2 available. If they're having an anaphylactic reaction, you call 911 if they're home. You want to call your stat nurse if they're at the hospital. There are certain protocols, especially in the hospitals, for anaphylaxis reaction. They have carts already for them, already ready with the meds that you would need to counteract the reaction. So if you think that your patient's having a reaction and you see it happening, that's when you want to be able to call your SWAT nurse and be able to call your charge nurse and say, look, I think my patient's having a reaction, so they can pull out the cart. There are already protocols on board for you guys to be able to be able to sound the alarm. Patient teaching wise, drug allergies. If they have an allergy to penicillin, they should be wearing a bracelet. Penicillins are your most common drug. So if anything was to happen, if these patients were to be in a car accident or something like that, and they would go to the hospital and they were unconscious and unable to say what they're allergic to, they're going to give them, more than likely they're going to give them a broad spectrum antibiotic, and it might be in that penicillin family. So if they have an anaphylactic reaction to penicillins, they need to be wearing their bracelets, so that way if in a situation where they can't speak and say what they're allergic to, they could tell already by the bracelet that they're wearing. So it is a medical alert situation. You want to have them take it with water to help with the GI effects. They can take it with meals. However, it will reduce the absorption of the medication. So basically, you want to either do it 1 hour before or 2 hours after meals, and then take it with water, rather than taking it with food, because it will decrease the absorption. Take the entire course of antibiotics. Of course, like with every other antibiotic, that's going to be the same type of teaching information. And again, we can't stress enough, make sure they use a barrier method if they're using a contraception, a hormonal contraception. All right, I'm going to give you guys a few minute break, and then all right, so the next class that we're going to go through is your cephalosporins. Your cephalosporins are all going to start with ceph. And each subsequent generation is able to be, they've made them so that now they are able to reach more of the CSF. They're going to be much more effective against gram-negative and anaerobes. And they're going to be less susceptible to destruction by the beta-lactamase. So they've made subsequent generations because they've figured out that they can make them better. And so we're up to the 5th generation now. If you see the first generation, there is still a first prototype. The cephalexin is a prototype of the first gen. Your 3rd generation is your ceftriaxone, which is the ones that you can give IM or IV. And what do we treat with ceftriaxone? It's usually given for pelvic infection. Which one? Which one? Gonorrhea. Very good. Okay. So these are usually used for UTIs, a lot of the post-op infections, your pelvic infections, and meningitis are the ones that we usually use your cephalosporins for. Mechanism of action. So these are also bactericidal. They will kill the bacteria by destroying the cell wall. The adverse effects that we do see are allergies, hypersensitivity, and again, anaphylaxis. So you might see urticaria, a rash. They might get hypotension and dyspnea. If any of these severely occur, you want to make sure you stop it immediately and you call your provider. You might also see bleeding tendencies. Your ceftriaxone and your cefotetan, they're more common to cause bleeding tendency. So you want to avoid using these for patients that have already bleeding disorders or that are taking any type of anticoagulants. Another adverse effect is thrombophlebitis. And thrombophlebitis is an inflammatory process that's going to cause a blood clot to form, and it's going to block one of either or one vein or more than one vein. Usually occurs in your legs, okay? And that's an adverse effect from the cephalosporin. And then you might also see antibiotic-associated pneumomembranous colitis, which is your C. diff. And you're going to observe your patients for diarrhea. And again, if you start to notice it, C. diff is the type, because it's caused by antibiotics, it has a very distinct odor. And if you start to notice your patients with diarrhea with a very strong, distinct odor, you're going to know it's probably C. diff. You want to stop the antibiotic and call your provider. Interactions that we might see, your probenecid is going to delay the renal excretion of your cephalosporins. So again, these patients, you're monitoring their eyes and nose. And then your alcohol, it's going to have an anti-boost effect. So you're going to see cramping, nausea, vomiting, headache, diaphoresis, hypotension. And this can happen even as long as 72 hours after finishing your antibiotic. Okay, so with your cephalosporins, it's one of those drugs that you want to avoid alcohol while you're on them, and even up to 3 days or so after you've finished the antibiotic, they can still have that anti-boost effect. So you want to let your patients know. That's one part. It's going to end up being one of your teaching aspects. Contraindications that you might see, again, anaphylaxis reaction to penicillins or other cephalosporins are going to be contraindicated, and any patient with renal impairment, you're not going to give it to them. You're not going to give them cephalosporins. Nursing considerations, again, assess for allergies to any type of penicillins because of the cross-sensitivity. Monitor your eyes and nose. Okay, patient teaching, report any unresolved GI upset, so nausea, diarrhea. Avoid alcohol. Your take with food to decrease the GI upset. So this one you can take it with food, your cephalosporins. It helps to coat it. You want to store the PO suspensions in the refrigerator. It keeps them active. Again, you want to take the entire course of your medication, and of course use a barrier method if you're on any type of hormone contraception. Your next class is going to be your carbapenems, like M&Ms. I like that. They're all going to end in your penem. So you have your meropenem, your imipenem, celastin. These are going to be your broadest spectrum of any type of antibiotic. Your imipenem and your celestin, which is your primaxin. Primaxin is a prototype drug. Right now, it's not out, but it's being used as a prototype. In this class, it's one of the most broadest spectrum ones. Mechanism of action, these are also bactericidal. Indications, we use them for very serious infections, usually reserved for those that are acutely ill, hospitalized patients, patients with complicated UTIs that are becoming uroseptic, peritonitis, pneumonia. And then your adverse effects that you might see, again, your allergies and hypersensitivity, GI upsets, nausea, vomiting, diarrhea. Any you might see drug-induced seizures. Your older patients and your patients with renal dysfunction are going to be at higher risk for your drug-induced seizures just because they have poor out renal function. So their drug sits in their system longer. And then any cross allergies with penicillin, anaphylactic reaction to penicillin should not get your carbapenems. And that's just because, again, they have the cross sensitivity. So you don't want to put them at risk for that type of reaction as well. Interactions. Your imipenem celestin can decrease the levels of valproic acid. So then it's going to put the patients at risk for seizures. So that's one med that could have an interaction with it. Contraindications, again, renal impairment and any allergy to penicillin. Nursing considerations that you need to look at. These you are going to infuse over 60 minutes. And you want to monitor those patients for super infections. So like for C. diff, thrush, yeast infection. Because it affects the CNS, they do have a potential for seizures, especially if they're on valproic acid. So those are things that you want to monitor your patients for, at least assess them for as well. Patient teaching that you want to include. Again, food does help to prevent the super infections. So live culture yogurt, probiotics. These specific ones are going to help to prevent those super infections like yeast or C. diff. You want to look for those signs and symptoms of those super infections. Again, take the entire course and use your barrier method for contraception. You know that's going to be a test question, right? What do you need to use for, what are you using for contraception? The barrier method. That's going to be a question. It's on every slide. That's a hint. Your other class, monobactums. This is going to be a azithromycin. This mechanism of action is bactericidal as well. We use it to treat MRSA and to treat C. diff. Adverse effects, rash, nausea, vomiting, diarrhea. It can cause ototoxicity, although it is rare, and it is reversible as well. Thrombophlebitis and renal toxicity. Contraindications, again, low cross reactivity with other Bactrim beta-lactams, and you're commonly given to patients with penicillin allergy. So we can give these with patients, to patients that have a penicillin allergy. Nursing considerations: infuse, diluted, and slowly. So you want to infuse it at a very slow rate. So these are probably going to be over an hour. Sometimes it could be over a few hours. And they're going to be in a larger amount of diluent. So somewhere between either a 100 to a 250 bag. And the reason is because it is a very strong drug, and so it can cause phlebitis. Macrolides is your next class. And these are meds that you can recognize: your azithromycin, your clarithromycin, and your erythromycin. These mechanism of action are bacteriostatic. That's a difference. So these will slow the growth of the organism. They're used as alternatives for patients that do have penicillin allergies. We can give them for prophylaxis for procedures. Adverse effects that you might see: nausea, vomiting, epigastric pain. So you want to give it with meals to help prevent those adverse effects. They can tend to prolong the QT interval and cause dysrhythmias or sudden cardiac death, depending on the condition of the patient. So you want to avoid giving it to patients that already have a prolonged QT interval. So if they're already in cardiac on the tele unit or having issues with their QT intervals, you want to avoid giving these types of antibiotics. Ototoxicity can occur. Usually it does occur with very high dosages, and we usually don't give that high of a dose. But you do want to monitor and report any type of hearing loss or vertigo or tinnitus that they might see. Interactions that these drugs might have: macrolides inhibit the metabolism of the antihistamines, warfarin, and digoxin. So you have to watch patients that are on digoxin because it has an increased risk of toxicity. Patients with warfarin have an increased anticoagulation risk. And also these drugs do inhibit the metabolism of macrolides. So they have an increased risk of toxicity, causing dysrhythmias and sudden cardiac arrest. So verapamil, diltiazem, antifungal or HIV protease inhibitors. These are all gonna inhibit the metabolism of the macrolides, so they're gonna not let it work, and then they're gonna cause toxicity or dysrhythmias because they're just gonna sit in the body. We use these macrolides for pertussis, diphtheria. We use it to treat chlamydia, pseudomonia, and strep infections. These are all different times that we would use the macrolides for. Contraindications: your liver disease and patients, again, with your prolonged QT intervals. Things as nurses that we need to consider: you want to monitor your PT, your INR, especially if they're on warfarin. You want to monitor liver function tests, especially if we think that they're going to be on longer than 2 weeks. And then patient teaching: except for with azithromycin, you want to take it on an empty stomach with 8 ounces of water. Unless you have GI upset occurs, then you can take it with food. You want to complete the entire course of medication. Again, use a barrier method of contraception and you want to report any type of signs and symptoms of ototoxicity. So hearing loss, tinnitus, those types of symptoms, they want to make sure you are reporting them. And your class tetracyclines, these are broad spectrum antibiotics. These will all end in cyclin. So your demacyclocycline, your tetracycline, your doxycycline, and your minocycline are all parts of this class. Its mechanism of action is bacteriostatic as well. And again, they inhibit the growth of the organism. We use these for chlamydial infections, Lyme disease, anthrax, for treating H. pylori, for treating rickets. Adverse effects that we might see, again, GI discomforts are going to be your most common. So cramping, nausea, vomiting, diarrhea, any type of esophageal ulcers. So as a nurse, you want to make sure you're monitoring your eyes and nose. You want to teach them to take it with meals to decrease the upset. But to know that it could reduce the absorption, and avoid taking it at bedtime, because that will help to decrease the esophageal ulcerations. Because if they lie down, the medication kind of sits in their throat, and it can cause ulcerations in the esophagus. So you want to make sure they're taking it during the day. It does cause tooth discoloration in kids younger than 8 years old and in fetuses. So tetracycline has a very strong affinity to the calcium, and it will bind to the calcium, causing the discoloration. So tetracycline is a medication that we do not give to pregnant women because of this reason, and to children under 8. It can cause hepatotoxicity, especially in very high daily dosages and dosages that are given IV. Other adverse effects like photosensitivity are going to be important teaching factors. They can, while the patient's on tetracycline and they get in the sun, it can cause them to have a severe or intense sunburn. So you want to teach them to avoid the sun while they're on the antibiotic, or to use sunscreen and to use protective clothing. And again, with those supra infections or super infections like C. diff and yeast infections, they still have the same ability to occur. So those are parts of your adverse effects. Interactions with these meds, they cannot be taken with milk or calcium. So if the patient's on antacids, they cannot be taken with that. They cannot be taken with iron or magnesium. So if they're on any laxatives, it will decrease the absorption of the tetracycline. Milk and calcium and iron, magnesium, they all bind to the tetracycline and decrease its efficacy. So that's very important to know. Those are very common drugs that if you don't know your patient is on them or takes them periodically, they might think that it's okay to take their laxative that day or their iron supplements that day while they're on the tetracycline, and they cannot. So that is important to know that. Your monocyclines and your doxycyclines also do have an increased risk of DIG toxicity. We use these meds, your tetracyclines, for acne. We use it both topical and PO. We can give it for periodontal disease, chlamydial infection, Lyme disease, anthrax, H. pylori, all the ones we've talked about. Rickets infection, patients that have thyroid fever or Rocky Mountain spotted fever. This is what we would usually use for those types of infections as well. Contraindications, Again, it's going to be children 4 months to 8 years old because of the discoloration of the permanent teeth. Pregnancy and nursing women, skeletal growth retardation stains the baby's teeth of the fetus, so we don't give it to pregnant women. And then any of those patients that have renal or hepatic dysfunction are going to be contraindicated as well. Nursing considerations that you need to look at as a nurse: you want to monitor for any of the signs and symptoms of super infection, and you want to monitor the culture and sensitivity results, always making sure that your antibiotics are necessary and effective. So we want to make sure we're giving them the right antibiotic for the right infection in the right organism, okay? Patient teaching: take on an empty stomach with 8 ounces of water. If you're able to tolerate it that way, if you need to take it with meals, you can, but it will reduce the or decrease the absorption. You don't want to take it prior to lying down, again, because of the esophageal ulcers it can cause. You don't want to take it 2 hours. You don't take within 2 hours of milk or calcium, magnesium, or iron containing meds. So it's a 2-hour binding limit. You want to again take the total course of the medication, use your barrier method of contraception, and again avoid the sunlight and wear sunscreen and protective clothing because of the risk of the severe sunburn. And with the photosensitivity, it can even last for several days after they've taken the medication, so you want to let them to continue using the sunscreen and the protective clothing for a few days after they finished it. In general, information for antibiotics, again, as nurses, we need to always obtain cultures before starting antibiotics. This is how we will be able to prevent these super infections and not giving antibiotics that are not necessary or that they're not going to work on the specific organism. So we need to do our culture and sensitivities. You want to ask about your allergies. What actual happened, what reaction? Patients are quick to say they're allergic and all they had was a GI upset or nausea and vomiting or a slight rash after the effect that appeared 4 days later, that kind of stuff. So you really want to ask them what happened and what's causing their, or what that makes them think that they're allergic to it. Continuously monitor for hypersensitivity, allergic reactions, especially 30 minutes, remember, after administration, and up to 72 hours after. Evaluation, again, how do we evaluate that the antibiotics are working? Is that we see a decrease in the signs and symptoms of the infection. That's how we know they're starting to work. So they're going to have, if they had a fever, they're going to have normal vital signs now, right? You're going to have another post-culture after their antibiotics, and their culture is going to be negative. They're going to have improved appetite, more energy. They're starting to feel better. That means that their culture, their infection that was kind of like overwhelming their system is now going away, and so they're starting to gain more energy, feel better. Their labs, their CBCs, their white blood cell counts are going to be decreasing, right? Because now the attack is over, and now their body's able to go back to normal levels, right? And then patient teaching, again, take the full course of medication. Provide the list of foods and beverages that will interact negatively. Give them that list so that they know what they can and cannot have. Report any severe adverse effects, like your hypersensitivity. Follow-up appointments, keep them. They're important because they will make sure that the infection is gone. Most of the time, the physicians want to see them, especially for pelvic infections. If we treat them, when we see them, we want them to come back in like 6 weeks so we can have a test of cure, okay, so that we know that the infection is gone, okay? And then encourage foods that may help prevent your super infections, so like your live cultures, your probiotics, your yogurt. That's going to help to prevent those super infections. Again, very important, educating about your contraceptive and using that barrier method. And then wearing that medical alert bracelet with their allergies, especially if it's an anaphylactic reaction. These are important teaching aspects that you want to make sure that we're covering with them. And that is it